2026. And we are trying to bridge the gap which is existing between from the technology side and what is required by the Indian clinical and research organization. That's our vision and mission. And if you want to get a quick glimpse of what Premas is doing, so we are part of all the major genome sequencing project which has been done in the country. You talk about recently concluded Genome India project as well. You talk about Guardian, you talk about Indigen. We have supported all those major sequencing projects. Now, I'll quickly jump to the topic of the presentation, which is all about power of prediction and burden of choice, that is ethics in genetic testing. And what are the ethical questions that we need to address is briefly talk about how the technology, and when you talk about technology, it is the genomic technology that should be used. Who should have access to the omics data? And omics data, not only your genomics data, it could be your genomics, proteomics, transcriptomics, metabolomics, all those kind of data which is going to have the clinical insights. And then how we are going to make a balance between benefits and harms utilizing this genomics data. Now, the most important question is when you submit your DNA for some kind of research application, who owns that sequence? Is it you? Is it the testing company? Or is it the society itself? Now, let's explore each of the ethical questions one by one. But most of you have seen movies which is related to something called Margarita with a straw, Pa, Gujaris, My Left Foot, and all these are talking about unique diseases. Some of them are unique rare diseases, and give us an idea about how the society is perceiving these kind of genetic diseases. There are two more movies which talk about something called genetic discrimination, predictive genetic testing, embryo selection and all. And there is another movie which talked about My Sister's Keeper, is all about ethical controversy of designer babies. Now we have the immense power with respect to genomics. And we all know that we are unique, and that's the truth. And that truth is recently concluded a 5 lakhs genome by UK Biobank, and it is talking about how we are unique, that earlier we were able to sequence genome sequence in 13 years, and that has taken around $2.7 billion money. Now we are sequencing a human genome in less than $1,000. And each person is unique with 4 to 5 million variants, and 1 out of 10 mutations doctors can act on today. Why it matters is 82 new disease links from the diverse non-European genomes. Just focus on the word of non-European genomes because I'm going to touch on very important aspect of diversity gap. And next is the future of health is genetics and the dynamic biology. What it answers is no more our average patient, everyone is unique, and we talk about personalized preventive care in that area. And what excites you more? Is it the fixed genetic code or how our daily choices rewrites it? Now, what India is doing with respect to the overall wellness in the country, there are many policies, and we have seen a panel discussion related to that which talked about we have a policy of biomedical guidelines, we have a National Health Policy 2017, we have a rare disease policies, and we have DVT initiative, something called Unique Program. And all these are supporting with respect to the genomic data or other data sets which is being developed in the country or generated in the country with respect to the sequencing part of it. And all these data are going to be part of something called Ayushman Bharat Digital Mission. So all of you have must seen there is a 14 disease unique ID. And these ID, sooner or later, maybe after a few years, will be able to tell you the entire clinical history or clinical journey of that particular patient. And how you are going to store that data, that is the most important question which will come in the next slide. But what is the mandate of Ayushman Bharat Digital Mission is creating a national digital ecosystem supporting universal health coverage that is efficient, accessible, inclusive, affordable, timely as well as safe. And who are the stakeholder to that? It could be your citizen itself, the professionals, facilities, health tech companies and state government. And this is the entire mandate of your Ayushman Bharat Digital Mission. So far 73.98 crores are already been AVA ID which has been created, and around 5.6 lakhs healthcare professional are already part of this initiative. Now, why this is happening? Because we are talking about One Health initiative for the entire country, and there is a sequencing project which has been completed recently by the name of Genome India project, and it talks about something called geographical diversity, eco-linguistic groups, and the ethics and the consent. And the title of talk is itself to understand the ethical processes of how this data is going to be generated and how the data will be utilized on that part. And why we have done that? Because this will help us in build a reference genome as a panel for the country's own population, considering we have 4,000 diverse population in country. Now, just a quick glimpse of this project is all about 20,000 samples collected, 10,000 genome sequence, 9,871 is the high quality genome, and we were able to cover the 83 populations across the pan India. What it led to, the reference genome build variant catalog, so that we will be able to guide genomics driven treatment strategies, genomics driven pharmacogenomic insights, disease association and genomic medicine infrastructure. More than 600 million variants with respect to SNPs has been identified, and 30% of that is novel to Indian population. Now, the most important part and ethics part is there, how we are going to store that data. And what this project is following something called Fair Data and Secure Access, which is all about findable, accessible, interoperable, and reusable of that data, and which talks about the infrastructure support as well. There is something called Biobank, where you are going to store all the samples that you have collected for the project, and this is going to be pullable for all the sequencing projects or any other bigger projects that we are planning with Government of India. There is something called Indian Biological Data Center, and then federated ecosystem for the access to that data, as well as secure access of data for the research application. And who is going to take charge of that? There is something called Biotech Pride policies, end-to-end encryptions, and tiered access model of the data, so that everyone, whosoever wants to develop some technology, they will get benefit from that. And where the things are moving, we are moving in an area of something called multi-omics. We are also moving something called panomics integration by the end of 2027. We talk about precision medicine trials that is supposed to start by 2028, and then more 50,000 genomes by the end of 2030, and which is all about building a genomic future for India, integrating all the policies that I have talked about. Now, the most important point is, what are the guidance? Do we have guidance, something related to ethical, legal, social challenges? Who is going to have access to data? So there is a Spanish guidelines, as well as there is a Australian guidelines, and Newfield Council of Bioethics, they talk about something called use of AI for the genomics data. And you will find on this topic, there is a lot of literature which is related to ethical, legal, social implications of genetics and genomics with respect to oncology, with respect to rare diseases, with respect to prenatal diagnosis. We talk a lot in the panel discussion of that, and the genetic discrimination of this data. There are emerging ethical challenges in the context of advancing genomic technologies. Now, when you talk about the genomics landscape, it is 2014 we talked about early commercial testing market which has been established. By 2020 we have expanded it to the clinical application and integration. By 2025 we have started doing a mass adoption and mainstream of the testing. Now, if you look into the accessibility, as I mentioned in the panel discussion itself, that sequencing costs now from $1 billion, it dropped to less than $1,000, and it is going to come much more down. And there is something called consumer adoption, because there is called direct to consumer testing, genomic service companies who is offering testing. They are taking your data, and the data is so valuable that it can be sold to some pharma companies. And the base of users grow from 0 to 30 million. Then there is a clinical integration, which creates more new ethical challenges for the patient care in the country. Now, when you talk about core bioethical framework, which talks about the autonomy of data, then beneficence, non-maleficence, and the justice, and it includes the key stakeholders, which could be patient, your family members, clinician itself, the insurance payers, and the regulator of the whosoever is regulating that access to data, or whosoever is making the policy with respect to a country like India. Now, when you talk about autonomy, you need an informed consent, and that's the role of a genetic counselor. Very important role whenever a patient is walking to a genetics clinic to go for a genetic testing. There is a role of a genetic counselor who will draw the pedigree, who will understand the genetic basis of disease, and then the right kind of test will be offered to that patient. Then, finding the actionable insights. And then once you observe some test, when there is a clinical finding or a genomic finding, how you are going to convey it to the patient, and equitable access to the testing with respect to the diversity gap in the population and genomics databases which is available across the world. When you talk about informed consent and autonomy process, you start with the test acceptance. You go for a pre-testing counseling, and once everything is finished, genomic data is generated, analyzed, you are going to get something called pathogenic variant, which have direct correlation with the disease of interest. You are going to get the variant of uncertain significance, we call it as VUS, or incidental findings, and there are guidelines to that. But sometimes all these databases or all the data which is being generated leads to information overload. And there is a technical complexity that you need to make a patient understand what this test means and what is this genetic information is carrying. So what you need to do is make the patient understand in the language that they can understand what they right to know and not to know, and what are the ongoing consent process, how the data will be submitted to the registry, and how it is going to be analyzed. For example, there is a case of BRCA1 family dynamics. This is just a hypothetical case. A patient reported with a breast cancer. Now there is a carrier for a 35-year-old female with a BRCA1. And you know that that patient refuses to disclose test result to the siblings, citing family issues and all. So that's the problem with the patient itself. Now the providers, whosoever offered the genetic test is, you have to respect the confidentiality. Then you also have to warn the family. So this is a double-edged sword that you have to balance in between. And now the most important question is, should healthcare providers override patient confidentiality to warn at-risk relative about the heritable conditions? So it is a challenging task for a genetic counselor or the consultant itself, that how will you communicate this to the family members, or if the patient just want to keep the data or the information with themselves. Now that's the most important point. We talk about something called privacy and confidentiality of the data, and there is something called unique privacy risk, that you cannot reveal all the information about the biological relatives without their consent. And there could be, no matter how data you are going to anonymize that, it can be re-identified using the technology which is present at the moment. And there is called permanence, that genetic information doesn't change over the lifespan, and the future interpretation may reveal unexpected findings. So how the data flow, that starts from a patient sample, goes to laboratory, and then the databases, and that data can be utilized by pharma, insurance, and the law enforcement agency. Now I just mentioned about incidental finding and unexpected result, that can be divided into pathogenic, VUS, and benign categories, and there is a guidelines which has already been established. And it might possible that you offered a test for a certain kind of genetic condition and you are not going to get anything, but there could be incidental finding for an unexpected disease or some other diseases, so you have to kind of convey patients accordingly. And there are patient perspectives and lived experiences, and these are just hypothetical example, that if you know about the genetic condition beforehand after a genetic test, you will be able to better plan your life, you will be able to better plan the time that is remaining with you, and there is common emotional responses which is related to relief, anxiety, empowerment, and the decisional conflict. Now I just spoke about there is a justice and access of the data. So there is a diversity gap. If you see that 76% of databases based on the European population. So we definitely need an effort like all of us have research program by the US to sequence 1 million genome. Then the Genome India initiative that I just spoke about, and there is H3 Africa program. And these efforts are required, or this is most important right now when you talk about the variant classification, because most of the variant are getting misqualified, and then there is a pharmacogenomic guidance which is required. Now, the most important point when you talk about ethics, because genomics is giving you the power of prediction, but what is happening with respect to something called direct to consumer testing challenges, that the accuracy and validation and genetic counseling, it could be with respect to your clinical laboratory and DTC services, both are on the equal level, or the DTC services is offering something minimal or optimal counseling. But when you talk about data privacy, clinical lab is basically your HIPAA and GDPR compliant, so that there is limited sharing. Regulatory oversight are always there, but when you work with something called DTC services, there is a warning sign. And the companies like well-known example of 23andMe, so there could be a third release of data for third-party data resale and the limited interpretation support. So there is always an ethics involved, that where we are submitting, what kind of consent we are giving it to the DTC people, that whosoever is going to utilize the data. And when you talk about the final aspect, which is legal and regulatory framework, that is what happens with USA, the GINA guidelines, the European Union, the GDPR guidelines, and the Canadian guidelines, employment, health insurance, life disability, and data portability. You can understand the level of protection that we are getting. And once you know about the genetic history or genetic disease for a patient, there could be an employment discrimination, insurance premium will increase, and there could be a social stigmatization and the loss of financial opportunities for that particular patient. So the role of a genetic counselor, the people whosoever is involved in the throughout process, from the collecting the sample, doing a patient counseling, as well as explaining the result to a particular patient, is very important. And what are the secure storage guidelines to store the data which has been generated from that particular patient sample. So this is just a quick best practice recommendation, that you need to develop a post-test follow-up protocols, or document informed consent thoroughly, or follow the pre and post-test counseling based on the National Society of Genetic Counselors, and shared decision-making frameworks which discuss both clinical unity and potential psychological and social impacts of that particular genetic test. Now, what are the key takeaways? That genetics is giving you the prediction power, right? Genetics is making you a patient-centric cared approach, but there is also an ethical responsibility. So that's where your sustainable genomic future is all about. And we also talk about our collective responsibility is to stay informed, engage patients, as well as advocate policy, what we have talked about in the panel discussion. Now, where the future is moving. As of today, that 2025 we talk about, we will be having a $100 genome, that is your WGS. Yes, AI risk models, newborn screening, and CRISPR add-ons. And there are few questions which is related to that. I'll let the audience to read that part, that how we manage the vast amount of genomic data and what it is going to give you. Prediction empowers us, but ethics must guide how we use the data and that power responsibly. That's the end of the talk. Now I'll quickly take 1 minute of time what we are trying to do in India with respect to our Premas Life Sciences Group, that we are supporting Illumina. Not only Illumina, we are supporting n number of companies. Start with the Twist by Nano, Chapter DX, Horiba, Bruker, Olink, and Spear Bio. And that's where your multi-omics is moving. You talk about genomics, epigenomics, transcriptomics, and proteomics. That's our sequencing solutions. Start with a small genome we can do, or we can empower your lab to do any kind of bigger sequencing project. And that's where the multi-omics is moving. The integration of technology and integration of life science itself. And there is something which is possible sooner or later, that we will be able to detect a disease like cancer as early 3 years possible. Right, and then we have recently launched our uncoded facility, that is from Premas House, that is our R&D facility based in Delhi, and we truly believe in Make in India campaign, in-house brand by Premas, carrying a 19 years old legacy and offering the cost-effective end-to-end solution for the country's population. And that's where, starting with the biospecimen storage, the NGS panel, and the bioinformatics platform, the end-to-end support with respect to NGS solutions from Premas House. And thank you very much. I'll be happy to take questions.
Thank you, Dr. Anuj, for excellent elaboration of a so much difficult topic, because genetics and is predictability, burden, and the importance is now increasing day by day in the modern science, as it is as the precision medicine is now coming in a practice. So early detection is much more important. So we are sometimes we forget about the ethical issues that is excellently elaborated. I will take the questions from the audience, but one question from my side. From your company end on these things, many government sectors and the private sectors, they are practicing the pediatric group and as well as now rare diseases. So how can your company can be help to them for as a logistics support or some giving a amount for the establishment of ethical issue and always for creating the state-of-art institute for the genetical testing?
True. Yeah. So I'll take the second part of the question. We are fully capable with respect to all the 19 years old legacy that we have built in India. We will be able to support the state of the art lab. And then ethical issues the organization needs to take care. We can secure your data. We can give you a lot of ideas that how the data will be secured. And then the organization needs to be in consultation with the national policies or national guidelines where the data will be submitted and how the data will be accessed by the third party, and the third party could be your general researcher and third party could be your pharma companies as well. So that's where we can support you establishing your entire lab with respect to all the expertise that we have. We can help you in the secure storage of data as well.
We'll take only one questions from the audience because we are running short of time.
Yeah.
I wanted to ask you, one of the problems we have is the EMR, hospital EMR. We get all the investigations in the EMR.
Yeah.
Should you put a genetic test into the EMR? Our hospital is not doing that. I don't know whether anybody is doing that and whether it is, because everybody can see that then.
Okay, perfect. So I'm not aware of whether the genetic test is a part of EMR as well, but what is going to happen in next 5-10 years, as I spoke about Ayushman Bharat Digital Mission, is every single patient data is going to integrate it with a unique ID, and that's the government mandate. Right, and it should be like who should have access to the data. It could be the clinician as well, and you have to put a special request or some kind of IDs which has been created. So as a clinician, you will have access to the entire patient clinical history, and which is not far. It is going to happen sooner or later. Thank you very much.
Thank you very much for excellent talk and this explanation. Thank you. We'll proceed to the next session.
Can I just disconnect my laptop?
We thank our chairpersons, Dr. Priyam Korpal and Dr. Pinaki Mukherjee sir, for chairing the sessions. We thank Dr. Anuj Pandey for delivering a difficult topic so beautifully. Our next talk is red flag signs for genetic renal disorders in OPD. And may I please request Dr. S.P. Roth and Dr. Jayanta Basu sir to chair the session. Dr. S.P. Roth is the past president of ISN East Zone, ex-HOD and pediatric nephrologist, SCB Cuttack. Dr. Jayanta Basu sir is one of the most senior pediatric nephrologists, and he was basically the first person to actually do a dialysis here in Calcutta. I welcome you, sir, and I would request you to please introduce our speaker, Dr. Hugh McCarthy.
Good afternoon, ladies and gentlemen. Now we come to the next second session of this afternoon program, and we have with us Dr. Hugh McCarthy from Children's Hospital, Sydney, Australia, and he's going to speak on the red flag signs in the OPD. As you all know that some sort of genetic element is there in almost all the renal diseases, and we have to identify in a busy OPD and there must be some high index of suspicion and red flag signs, is going to discuss on these things. Dr. McCarthy, please.
All right, thank you very much, and thank you to Dr. Rajiv Sinha and the organisers for the invitation to come and speak to you today. Rajiv and I trained together many years ago, or at least it feels like only a year or two ago, but the mirror tells me otherwise. But I want to start with two bits of two random facts for you. Firstly, Australia is almost 2.5 times the size of landmass of India, but our population is 27 million. So it's entirely possible that your patient cohort is slightly bigger than my patient cohort. And the second random fact is that it looks like India might actually win the one-dayer. Some minor disclosures. So certainly over my practicing career, over the last 10, 15 years, we've seen this enormous shift in the way that genomics is utilised, moving from a research tool to a routine clinical practice. And the next generation of nephrologists are not going to understand that this was never a thing, and they're just going to be using it every day. And that's being mirrored in the way that the genetic knowledge is increasing all the time. Our access to testing is increasing, and our variant interpretation is improving, speeding up, and all this is going to carry on improving. So genomics is an incredibly powerful tool available to us now, readily available to us now, and the question is, who should we test? And it's appropriate that we think about that and we don't just blanketly test everyone. But we have a problem, and this is KDIGO Controversies Conference from a few years ago, and I don't know if I agree with it, and I think, gee whiz, if the KDIGO Controversies is not completely straightforwardly accurate, then we are in a position where we don't know very much. So talk about 600 genes, I'm not sure that's really true. 50% of the non-diabetic CKD and paediatric cohorts, actually the references for that were very, very weak, and 30% in non-diabetic adult cohorts. But you know, this is where we're at the moment. I think what they did say that was true, estimates of the prevalence of monogenic CKD are currently imprecise. I think that would be an understatement. All right, so here's a typical case. This is a case one of my trainees saw in a regional clinic, and she's a pretty smart cookie. She's now a colleague of mine in the Children's Hospital. She saw a child with congenital nystagmus, and she's a good paediatric trainee. She took a family history. And dad has got FSGS, and his sister has got FSGS, and there's a cousin and an aunt. And she said, I wonder if that's connected, and sent the family up to us. So what do we think? Has anyone got any suggestions? Optic pit or optic nerve dysplasia, FSGS. Could there possibly be a connection with some apparently unaffected relatives in the meantime? Well, we actually only did single gene sequencing for this because one of them, the aunt, was pregnant, and we wanted a result quickly. So we got a clear hit in PAX2 renal coloboma. Both the renal phenotype and the eye phenotype are extremely variable and can skip a generation, as we like to say. So what's the first red flag? Well, phenotype. I think this stands true pretty strongly. One way to determine your risk of a genetic origin to your disease is by looking at your phenotype, and this is probably much easier in the pediatric cohort than it is in the adult cohort. And within each of these subsections, you need to break it down into those with a risk and those without a risk, and that's easier said than done in some of them. So let's take glomerular disease, for instance. It's relatively straightforward to identify those with risk of a genetic disorder. Familial steroid-resistant nephrotic syndrome, yeah, that's a slam dunk. Alport syndrome, that's a slam dunk. And we're extremely unlikely to offer genetic testing for steroid-sensitive nephrotic syndrome, sporadic steroid-sensitive nephrotic syndrome. What about membranous? You're not going to offer that, or IgA nephropathy. So relatively straightforward. But what about something like persistent microscopic hematuria in a girl? Maybe you're going to pull the trigger a bit earlier. And some of the other phenotype cohorts can be a little bit tricky, and these are a couple of examples. So Kakut and Stones, and we just kind of made this up in our own practice that it seems to us that to pick up diagnostic hit rate for monogenic disease in the Kakut population is pretty low, and so you should rationalise who you're testing. And one of the ways to try and rationalise it, well, is the family history, extrarenal manifestations, or is it really progressive? And if it's going to lead to end stage, then you probably earn yourself a genetic test. Stones, again, you know, stones in children is pretty rare, but sometimes you see it with infections, and you know, if there's a delay in drainage, PUJ, VUJ, then maybe you're going to see stones. But in the absence of those, or with a family history of biochemical clues, then we reach for a genetic test. Sometimes, particularly, this is pediatrics really, it's relatively straightforward. You're going to have to find a reason not to test. And so phenotype kind of drives it strongly. Age of onset really comes into it. The earlier you present, the higher risk, and makes sense. And you see that probably most clearly in congenital nephrotic syndrome, steroid-resistant nephrotic syndrome. You present within the first 3 months, you've got an extremely high chance. But if you present at the age of 18, you've got a pretty low chance. We actually wondered about this. How good a tool is it? Genomics in SRNS, pediatric SRNS, and this is probably only relevant for our pediatric colleagues, but why do we always do a biopsy first as a first-line investigation for steroid-resistant nephrotic syndrome? And is there a better way? So we did a very simple retrospective cohort analysis, and we looked at all those that children presenting with primary steroid-resistant nephrotic syndrome, where they had no atypical features, no macroscopic hematuria, no abnormal complement levels, nothing like that. And we got 2 children's hospitals in New South Wales, and we identified that overall genomics really only changed our clinical practice. We only got a really strong genomics hit in about 13%. That's interesting. So we always quote childhood SRNS, you're going to pick up rate of about 20-25%. And there was a retrospective study from GOS a few years ago where they said that's overestimate, it's more like 15%, and yep, 13% in our cohort. But actually there's an age where genetics is much more likely to give you an answer that's going to change your management than histology is, because the chance of finding something other than minimal change or FSGS is pretty low. And those 2 lines cross over around the age of 6, interestingly. So maybe we should be doing a genetic test for children under 6 as a first line, if you had a magic wand and you could get it back within a week or 2. Extrarenal manifestations, probably flag number 3. And this is a snapshot, is by no means exclusive, but you can see that there's a variety of extrarenal manifestations associated with monogenic kidney disease. And what does that tell us? It tells us we have to be really careful to examine our patients, take a history and examine them, and then organise appropriate testing if we're at all wondering about the monogenic cause. So I say to my trainees, always consider an eye review, a hearing check. These are things that you could miss on a clinical examination, extending the abdominal imaging and potentially asking for an echo. Got to keep those cardiologists busy. Family history, obviously really, really key, and they don't always look as neat as this. The consanguinity, we see an association, but I think we need to be careful not to be too judgmental about that, certainly in our practice in Australia. But family history, sometimes there are clues, but they're not really clear cut, and coincidences are always kind of trigger me a little bit with in terms of family history and genetics. So we had a look at, this is an example, we did another retrospective cohort study, got to keep our trainees busy. We had a look at children diagnosed with X-linked Alport syndrome. We went back and had a look at their parents. 35 families. In 8 of those 35 families, one of the parents was known to have X-linked Alport syndrome already. In the rest, well, 2 didn't get tested, 4, it was de novo, neither parent was affected, and in the remaining 21, a parent was unknowingly affected. So that's over 60% of our kids with X-linked Alport syndrome. We're making a retrospective diagnosis of a parent afterwards. And, you know, it's bizarre because 3 of those had already had a kidney transplant, and so they'd been misdiagnosed. And the majority of them were female, and there's probably that unconscious gender bias actually about recognising underlying medical disorder. Now, what's interesting is that they had a variety of GN diagnoses already. Could have been microscopic hematuria, proteinuria. Some of them had IgA and some of them had FSGS. FSGS with hearing loss, interestingly. IgA can be one of those banana skins that you can slip on. There is sometimes they do coexist, IgA plus Alport syndrome. And, you know, in almost a half of those that were unknowingly affected, there were 2 generations affected with a GN that was undiagnosed. Okay, what about if CKD is of unknown etiology? Well, this is actually a relatively new cohort of patients where we've identified that there is a significant genetic risk. So this is something we did in Australia. We took prospectively 100 patients with end-stage kidney failure before the age of 50. It's a pretty low cut-off, if you ask me. Where the standard of care testing, they'd had no cause identified. And we ran a whole genome on them, and 25% of them had a clear likely path or pathogenic variant identified. And you know, you could break that down, and about a third of them were in a glomerular gene. So what this tells us is that if, and this is true for children and for adults, if they're presenting in end stage and they don't have a clear cause, then a genetic test is really worthwhile. 25% is actually a higher hit rate, much higher hit rate than some of our other standard phenotype groups, such as CACA. And this is replicated in other cohorts, including a French one, which I have failed to reference, my bad. 230 patients, they went slightly older, again undiagnosed using standard testing, and whole exome sequencing identified 30% hit rate. And so, yeah, we've got to be identifying that this is a patient cohort who should be offered genetic testing. So look, red flags help direct testing appropriately, and they give you a clue. So we understand that genomics is here to stay now. We need to integrate it into our routine clinical practice. Someone said this already, early recognition, much better for the patient, earlier diagnosis, much more structured therapeutics. So we would say that the main trigger for identifying whether to test or not is looking at the phenotype, but weighing in together with that young age at onset, presence of a family history, albeit slightly unclear, extrarenal manifestations, and then you probably have a lower threshold if a patient or a first degree relative are thinking about family planning, considering a pregnancy, and what about if there's potential for a living related donor? You would have a lower threshold, I think. So look, I'll finish up there. I think I'm a little ahead of schedule, so buy back some time, but I'm happy to take questions. feel comfortable. I think there's a little bit of clinician gut feeling where you don't feel comfortable that this is easily explained by lifestyle or anatomical. Then we should have. I think Stones is one of those conditions where there are a couple of therapies that are available. If you cystinuria, hyperoxaluria now, and so we should have a lower threshold for testing because it may have an influence on therapies. For instance, the hyperoxaluria cohort, we had a look at it in Australia. We thought as a pediatrician, I thought hyperoxaluria, surely I'm going to know all the patients with primary hyperoxaluria in Australia. I just asked my pediatric colleagues. And what we found is that, yes, the majority are identified in pediatrics, but there's a subset who go into end stage, get a transplant, get recurrence in the transplant, and is diagnosed post-transplant, and which kind of was really surprising to me. So I think that I think they're hard to diagnose clinically, and where there's a therapeutic option available, lower threshold to test.
In fact, maybe two. First is we were when I read that article from Goss about that 10 to 12% of actually they are finding a genetic cause for the SRNS. So has that been replicated anywhere else? Because whenever we are asked, we are still quoting about 20 to 30% of SRNS are genetics.
Well, I think that paper was the first one to suggest that it wasn't 20 to 25%. And I think it probably depends a little bit on how you look at the numbers, whether you include congenital nephrotics as part of those primary SRNS or not, because that'll bump your numbers up. I think that the cohort wasn't huge, and I think it was probably slightly dismissed as just annoying and didn't really follow what everyone else has been saying for the last 20 years. But as far as I know, no one else has published that, but actually that was almost,
So what are your indications for doing genetics in nephrotic syndrome, apart from obvious malformations, etc.?
Yeah.
Do you do it on all steroid-resistant nephrotic syndrome, or only for the CNI resistant?
Yeah, so great question. So we think we do it on, we actually went into that study thinking we do testing on every single child with primary steroid-resistant, in fact, we do it for all children who develop steroid-resistant nephrotic syndrome because of the therapeutic potential to change the therapeutic management. In fact, we don't, because if you come in age 12 and you have a biopsy first and your biopsy shows membranous or IgA, then you don't get a genetic test. So we are a little bit self-selecting, but for those that don't, where the biopsy doesn't rule out something else or doesn't show you something else, we are generally advocating for all of those children to get a genetic test because of the potential to reduce exposure to immunosuppressants.
Because the Indian guideline says, as Anil will be saying, is we are limiting it primarily to CNI resistant. So we are giving CNI. Obviously, if there's other external manifestations, that is something else. We are giving CNI, waiting for about 2 to 3 months, and then doing it.
The two problems with that is that there is a little bit of anecdotal data, maybe you guys were part of it as well, where there was a large international cohort that published.
CNI responsive, that also I think we are taking with a bit of salt.
Yeah, we didn't see any. And the other thing is that, I know it's for you guys it's probably a pretty tiny cohort. If you come from Southeast Asia, particularly China, and you develop steroid-resistant nephrotic syndrome, there is a chance you've got a COC8B variant, and that may respond to, over-the-counter supplemental medication, which is huge, right? So depending on where you are in the world, there's a subset of patients who are going to respond to an over-the-counter supplement. And so, in Australia, it's a pretty mixed cohort, so we would argue that it's worth using a genetic test as an
Any other
first-line
questions?
investigation.
Because definitely this talk will be setting the road for the entire evening. of when we should be suspecting about the genetic disorder. If not, I think I can hand over to Dipanjana for the, like, concluding it, yeah, and the chairperson.
If there is no more question, we thank again Dr. Hugh for this excellent talk, and we conclude the session here.
Thank you.
Thank you so much, Dr. Hugh McCarthy, Dr. S.B. Roth, and Dr. Joyanto Basu. I would request all to please collect your memento at the small stage beside us as we move on to our session 2. Our session 2 is on practical work. It is moderated by Dr. Rajiv Sinha and Dr. Debrina Dashgupta. And our first talk over here would be setting the stage, ACMG and AMP guidelines and clinical interpretation in kidney genetics. May I please ask Dr. Orgho Mojumdar, nephrologist and transplant physician, Manipal Thakuria, to please chair the session, along with Dr. Ritesh Kuntia, nephrologist and transplant physician, Fortis Hospital, Calcutta, and Dr. Yes, so thank you, sir. I would request you to please introduce our speaker, Dr. Kaushik Mandal.
Well, good afternoon. Well, we all have variants of unknown significance. The main problem is to find out, which one of these are actually pathogenic or which one is benign. So the American College of Clinical Geneticists, they've laid down some criteria, and we'd really like to know about these, how to identify these pathogenic variants. And to tell us all about this is Dr. Kaushik Mondal. He's a MD in pediatrics and DM in medical genetics from SGPGI Lucknow. And his work experience is from LHMC New Delhi to CMC Vellore to SGPGI. And that's where he is stationed at the moment, at SGPGI. He's professor and head of the Department of Medical Genetics there. And with this vast clinical expertise in this field, it would be a pleasure to hear from him. Welcome, Dr. Kaushik Mondal.
Thank you, sir. Thank you for this opportunity. So this presentation is entirely targeted for academic purpose. There will be many things which I do not know. So I might be telling wrong also. And but it is always a collaboration, and we'll share thoughts. The facts and figures are collated from different sources and should not be quoted without verification. There is no financial relationship except for the fact that Rajiv Da has called me here, even though I fight with him a lot. There is no conflict of interest. So medical genetic services involves various people, pediatrician, genetic counselor, and we have prenatal testing, laboratory testing, and everybody these days require medical genetic services. It's a multidisciplinary approach. And when, it is not that I do not know the way of test, but I have written it as tests. Many of you who have used genetic tools have used a online software called Mutation Tester. So it is also written as TASTER, tester, right? So when we do the genome is a Pandora box. So it will open up with lot of variants. Even one variant is reported, the clinicians do not go to the lab. Whatever the lab has reported, they will try to move it towards something which is actionable, right? And the lab scientists, especially the data scientists, will try to tell that this data is probably not useful. They will report it and they will tell it is not useful, right? And you see that I have made a fetal medicine expert who is on the clinician side, who will win even at pulling that. So sometimes even without understanding, many of us, if you don't understand, we can do a prenatal testing and people can abort babies who are not really affected, or there can be too much inclination to a site where they have proven that this is not actionable and we have not taken an action, neither for treatment nor for prenatal testing when the variant is really important. The clinical geneticist in between plays a role to bridge this and make a sense out of it, but sometimes we are only left with few guesses. So remember that whenever I do a test, especially in situations where the clinical scenario is not very clear and we are doing it pregnancy, we tell that the more tests we do, more uncertainties we can land up. So there can be uncertainties which the patients, patient relatives and the clinicians have to bear with. So before riding a motorcycle, we'll know the motorcycle parts. Without knowing the motorcycle parts, we cannot ride. What is a fuel tank, what is a oil tank, all those things. So I will tell few things about genetics so that whenever we venture into this process, we will be knowing this, that you know that while we look at the karyotype, we look at the books from the outside. While we do FISH, MLP or CMA, we look at a few deleted paragraphs or repeated paragraphs or few torn pages in the books. And when we look at the DNA, so you know these are histone proteins and DNA is coiled on the histone proteins, and one chromosome is one long DNA from PR to QR, and everything is written in 4 letters, A, T, G and C. So we have to extract DNA till chromosomes we can see with our eyes, but for all other molecular tests like microarray or anything for sequencing, whether it is targeted sequencing, we have to extract DNA. And sequencing looks at spelling mistakes, only few letters are missing or few letters are duplicated. So these are the way of resolution, but remember that what we want to look at karyotype may not be looked up by an NGS. This we have to remember. And these are variations in size. What we call is a single nucleotide variation is 1 base pair, right? Then 2 to 50 is called MNV. Then more than 50 is called SV, or more than 100 kV is called a large SV, that is large variations. And there can be copy number variations. So more than 100 base pair is generally called a copy number variation. So copy number variation can be deletion, duplications or tandem repeats, right? This is how the flow of copy number variations came, how we have started looking up to copy number variations. Now we can look into copy number variations. Now it is told as more than 50 base pair is a copy number variation which is looked by NGS. So we have pipelines to look at the copy number variations. So when we talk about variations, it is not only one substitution, right? It can be few base pair deletion, few base pair duplications, or a copy number variation when it is more than 50 base pair. So what is a SNP, single nucleotide polymorphism, and a single nucleotide variation? SNP is just a substitution, right? One nucleotide is substituted by another. But single nucleotide variations means it can be one nucleotide deletion, one nucleotide duplication, or a substitution. So all SNPs are SNVs, but not all SNVs are SNPs, right? So these few things we have to remember in mind while we go along. What is minor allele frequency? We will repeatedly tell that the minor allele frequency is more than 1%. The minor allele frequency is more than 5%. So minor allele frequency is the frequency of the second allele. That means in a genome where we know that there should be a C, right? You have find G, right? So G is the second allele. And if it is found in the population in a frequency of more than 1%, then you probably think that it is probably not a pathogenic condition, right? Or it is probably not giving rise to pathogenicity. So that G, the frequency of G is called the minor allele frequency. So what is allelic heterogeneity and locus heterogeneity? Allelic means different mutations for the same disease, right? Same gene, different mutations is called allelic heterogeneity. But locus heterogeneity means the phenotype may be similar, but there are different genes for the same phenotype. Like for Cornelia de Lange syndrome, what you know, so there are more than one gene. So this is called locus heterogeneity. Deafness, right? Deafness can be due to various genes. So deafness has a locus heterogeneity. then we'll know that there is human genome variation database or nomenclature. So we have to give all nomenclatures through what HGVS has given. So you can go to the website and see. Then we have something called a genome build or a transcript. So if we give an ID of C.1342C, so that can change, that number can change according to the build of genome you are using, right? So that is what is called a genome build or a transcript ID of that genome build. So you must be seeing that in your report it is written as ENST ID or NMID, right? So these are two different ways of telling the same thing. So now people have brought all these things together, and now we have started giving something called a main select ID or main ID, right? Then while you classify variations, you will see that you give a score when there is a nonsense mediated decay. Nonsense mediated decay is a process where if there is a stop codon, the mRNA is formed, that mRNA undergoes a decay so that negative or bad protein or deleterious protein is not being formed. What is cis and trans? Cis means both are in the same allele or same copy of the gene. You know that we get one copy from the father, one copy from the mother, right? So if it is in the same copy of the gene, we call it in cis. When it is in the different copy, we call it as trans, right? So we get something like this. So this is a Sanger sequence. You see two heterozygous peaks. So how can you make out whether this is cis or in trans? Please be interactive. How can? So we test the parents, right? Here we test the parents. So one parent should be having one, the other parent should be having other. Then it should be in trans. See, if both one of the parents have both, then it is in cis, right? So probably this is not the cause of the disease if it is an autosomal recessive condition. And when they are in trans, we call it compound heterozygous, right? For a homozygous, we do not know. It will look at single peak or the same area will give one, like C, it will give C every. Then we have to compare with the genome or the reference genome where it should be a G. So this process is called a BLAST, basic align search tool. So these are the few things. So I have told you that we have to give nomenclature for what genome build or what transcript ID you are using. We give it as a NMID or a NST ID. Now we give it as a main select ID, which is what is a C dot number? I will probably, yes. So what is the C dot number? C dot is not cDNA number, right? So many people would misinterpret it as a cDNA number. C dot number is the number of nucleotides when you start counting from the first nucleotide of the exon 1, right? You know that all genes have exons and introns. Introns are splices of exon come together, which is translated as a protein. So in the mRNA, if exon 1, you know that every transcript starts with methionine, ATG, right? So A is 1, T is 2, G is 3, right? Then you keep on counting. So if the last nucleotide is 92, anything in the intronic, so these are called splice site variants, like you give it in plus or 5. So plus 1 is one nucleotide after the last nucleotide of the first exon. For exon 2, right, if see the C dot number starts with 93. So it is not for all genes, this is for this gene, right? So different genes will have different C dot numbers. So if you want to designate anything proximal to exon 2, you will write 93 minus 1, 93 minus 2, right? The number of nucleotides between exon 1 and 2 may be very huge. So you don't write 92 plus 314. You will write 93 minus 2. Am I clear? So it is the proximity of the exons which you will give. So you see that this is a large deletion a small deletion where you write 26 to 29 del. You can just write del, you may not write CTT. So these are 4 nucleotide deletions. When there are big deletions, you write with different nomenclatures, right? So cDNA number, G dot number we give when we do not have the C dot number. If it is a very large intronic or beyond the gene, we can give it in a G dot number, that is genomic number. Then we give plus or minus, I have told. So anything proximal to exon 1, we don't write, we just give plus, right? Sorry, minus. So we'll write minus 92, right? So 1, so we'll not write C dot 1 minus, we just write minus 50, minus 92, anything proximal to the exon 1, we call it untranslated region. Anything distal to the last exon, we call it 3' untranslated region. So my time is getting over only by explanation. So for small things we do targeted sequencing. For larger genes like Meckel-Ruber syndrome, where there are cystic kidneys, like this, it looks like this. So we need NGS, and whenever we do NGS, we need to have a variant classification. So in 2015, it came like this. So you have to actually go through the paper and find out how it is to be done. So these are few databases which are used. Population, first you start searching in the population database, whether this variant is very commonly told, reported in the population database, then probably this is not useful. Then these are the in silico predictive tools which you see we do. Then these are evidences of pathogenicity. We give numbers at PVS1, strong PS1, PS2 like this. Then moderate supporting. Then we collate all these things to tell each criteria needs to be described and read meticulously. Then we have some for different, then we collate all this to tell whether this is pathogenic, likely pathogenic, benign or likely benign. So it is not something which I can explain in 20 minutes, but we have to go step by step, and probably throughout the day we'll do this exercise to tell you which criteria we can put, what the lab has put. When you have more information, you can refine your criteria. And then this is a framework. This is assessment of various frequency in curated form when you know about the gene. So what Dipanjana has given the topic previously to me is ACMG 2024. So 2024 there was no single publication of criteria, but they have changed. So they have changed something. That means they have involved CleanGen, where you have gene specific guidelines. So you go to this web page CleanGen, then you can type the gene symbol like PKD1, adult polycystic kidney disease. This is something which CleanGen have. So there will be gene specific criteria for some genes. For many other you see PKD something, they have not curated, so you cannot use CleanGen for that. So once you have a gene specific criteria which is there in CleanGen, you can go to the gene specific criteria and it will be very, very correct, right? So because they have already curated the data for that gene. So then you can go to CleanGen and see that you can use your ontology terms to know about the disease, whether it fits in your disease or not. So, and you can see all the variants and all the other genes where there can be variants for adult polycystic kidney disease. So this is something which is important, and as I have told you about what we should use is now MEN-Select ID, right? So this is what. Then we have these two very important tools, Varsam and Franklin. So you can put it in. Franklin is very useful. They will try to, and they will also give a link if there is a gene specific guidelines in CleanGen. So if once you put your variant, so you have to put the gene name, then colon and C dot number, then you can put whether it is heterozygous, homozygous, what are the features. Then it will give you idea about whether it is likely pathogenic and what ACMG guidelines they have used to give that pathogenic or likely pathogenic tag to that variant, right? So there is some learning objective. I will not go into details. So this is I shared from one of my colleagues. So this is the gene. You see that the lab hemophilia B. Previous baby had bleeding, so we start thinking. And mother was the baby was hemizygous, and the mother was heterozygous. But we actually had found that this is likely benign, and the pregnancy was already very advanced when they came to us. But see, we can use this gene specific criteria for this, and here we can start giving points, right? So we can start giving points, And see, this is very important, that this variant is found in many males, unaffected males, right? So these have a gene-specific criteria, and when this variant was found in so many males in the population database, then we could rule it out as benign. And the baby was born, the baby really did not have hemophilia B. Whether the previous baby had died of some bleeding disorder, that can be various bleeding disorders. So retrospectively, it is not very prudent if you have not really have checked. Had we checked the baby and found that factor 9 was deficient and we found the variation, it could have given us more evidence that the baby had bleeding disorder due to hemophilia B. Anyway, this actually solved this and we were saved. So this is the total points which we have given, and the final score we did as likely benign, though we have found a very important variant in a very important gene which causes bleeding. So bleeding disorder, so this is locus heterogeneity, so many causes of bleeding, right? So we cannot just stick to one gene if you have no evidences. So the outcome and message is that overall assessment of the variant was likely benign, and clean gene specific databases should be used. So when using in silico tools, one should use one tool in a pre-decided way before seeing the results of other criteria, and tool specific threshold by ClinGen has been defined. Our genome is a huge amount of information. We need reference to compare, and we have set rules for that. Reading the information is no longer a big hurdle, and it is economically viable. We can do whole exome. And why we do whole exome? Because more than 80% of all the variants are in exons, and the exon intron boundaries, so we do exome. So understanding the variation is the real challenge. Phenotyping is the cornerstone, phenotyping is the key. And if you have any other biochemical or other evidence to prove, so do prove it. We need proficient AI-based tools and we should be open enough to work together as a team, right? So this is my old team, this is our old team, this is Dr. Priyanka, who actually taught molecular genetics us. She is in PGI Chandigarh. This is Deepthi, who is the fetal medicine expert with us. This is Shashank. This is Brijesh. They do sequencing and microarray for us. My family and my extended family who rides motorcycle with me. So thank you so much. And a small advertisement. We do a 15 days course of genetics every year. And so this time we finished in September. So all of you are welcome. So our country have learned genetics. Many of them have learned genetics from this course of 2 weeks which we run every year in our department. So thank you so much.
Thank you, sir, for a wonderful deliberation.
Report. So that helps. So having a basic knowledge of ACMG criteria, how to interpret is important for everyone, especially when you are in the first genetics forum. That's my opinion.
So I am very sure that we have set the stage, and as Kaushik sir always has sets it, so it has been a very wonderful presentation. Right now, we will move on to the hands-on section of the workshop. And I understand you just had your lunch and you're feeling lazy and you're back in your seat. But I will ask you to be on your feet. So we actually, the way we have designed this is that we divide this hall into 4 parts. In the 4 corners, we have 4 tables, the table A, table B, table C, and table D. And what we intend to do is actually give you that flavor of what you get in clinics. So for all the tables we have table A, pedigree, which will be right to this side, this corner table. We'll have myself and Dr. Satish Balan sir discussing certain cases on pedigree and how to draw it. At table B, we have variant interpretation. You can ask Kaushik sir all the questions you did not ask, and Dr. Hugh McCarthy. Table B is right at that corner. We have table C, genotype phenotype interpretation. We have Dr. Anil sir, Dr. Subal Kumar Pradhan sir, and Dr. Deblina Dasgupta. It's right on that corner at the end. And we have table D, pre-test and post-test counseling. We have our beautiful genetic counselors, Ms. Yashodhara Bhattacharya and Ms. Upasana Mukherjee, along with Rajiv Sinha sir on that corner, the other corner at the right at the end. The way I am distributing the hall is that the faculties can please take their positions in the tables, like it's table A, table B, table C, and table D. And table A is pedigree, table B is variant interpretation, table C is genotype phenotype, and table D is pre-test post-test. I would request the delegates or even the other faculties who are interested to please join the tables. So the way I would request it is, please, the first row, whoever is there, can you please move on to this particular table over here, which is pedigree A, table A pedigree. The second row can move to table B. Everyone sitting on table row can move to table B. Would request the faculties in table B to please take their position. Faculties in table C, please take position, and the people in third row, please move on to table C. And the people in the fourth row, for each table we have 20 minutes. So please, if you can please be seated. So each table, after 20 minutes, the faculties remain at the table. The delegates will move to the next table. So people who are at table A, the delegates will move to table B. Then after 20 minutes, they will move to table C and then table D. Similarly, the faculties will remain. People who are at table B will move to table C and table A, table D and table A, and henceforth. So it's a clockwise rotation we will do, so that in 20 minutes, 4 times, we cover all the tables. So I'm requesting, please distribute yourselves among the 4 corners so that we can start.
So a very good evening to all my esteemed faculties and dear delegates. With immense pleasure, I welcome you all to the inauguration ceremony of our event. Actually, we have been having a Sister Renal Center program with Birmingham Children's Hospital in UK for the past 3.5 years, with the aim of enhancing our clinical potential in the division of pediatric nephrology in ICH. And nephrogenetics is one of the key focus areas for that. So for the last 3 years, we have been having this annual nephrogenetic clinic as part of that collaboration. And for the last 2 years, we have combined that with our ICH annual pediatric nephrology update. And this year, we have been even more blessed to have the association of the ISN East Zone. And we are really thankful to them for their steadfast support. Without further ado, I would like to invite our esteemed dignitaries to come up on stage for the inauguration ceremony. First, I would like to invite Professor Dr. Apurva Ghosh sir, who is the Executive Director of Institute of Child Health, Kolkata. Sir, please come up on the stage. Then I would like to request Dr. Shoshibhushan Raut sir, who is the past President of the ISN East Zone. Dr. Dibyendu Rai Chaudhuri sir, who is the Central IIP representative from West Bengal Academy of Pediatrics. Dr. Jayati Sengupta ma'am, who is the Secretary of Bengal Society of Pediatric Nephrology. Dr. Pratik Das sir, who is the Secretary of ISN East Zone. And Mr. Madhav Chakraborty, who is the State Coordinator of AKI Warriors. I would request Dr. Apurva Ghosh sir to please come forward and say a few words.
Few words about whom? I mean, if I need to talk about, I need to talk about Rajiv and his team. And what I see every day that Rajiv is really taking forward this department to a great height. And for this, he always fights with me because Institute of Child Health is a not-for-profit hospital and we have got fund crisis. But Rajiv always tries to bring funds and also wants us to do some improvement in the Institute of Child Health. So only one word I can say that I am really proud of pediatric nephrology unit and the team like Devalina, Songita, Samjuta and every other team and Shakil Akhtar. So I'm really proud of Institute of Child Health. Thank you.
Thank you so much, sir, for those words of encouragement. Next, I would like to invite Dr. S.B. Raut, sir, to say a few words.
Good evening, everybody. I must thank the organizers, especially Dr. Rajiv and Dr. Pratik for inviting me here. This is a great learning experience. Today we went through the course of genetics, and at this age we become again students, and it's very difficult to appreciate and absorb this knowledge. Knowledge has gone so fast. As regards pediatric nephrology in the Odisha list, we have dearth of specialists. When we started our career, we are managing all pediatric patients. All pediatric patients were doing peritoneal dialysis. That time it was not possible to do hemodialysis. Then we got this advanced patients who used to take selective patients where you can do hemodialysis. That time we wanted the pediatric nephrology to develop, and from our state, Dr. Sogol went to Canada for 1 year and came back. We always extended kind of cooperation for development of pediatric nephrology. But sometimes the resistance comes from the in-house. Many times the juniors are trained in the nephrology, they are not given any good support. Even they don't agree to expand the department. So initially there are a lot of hurdles to get machineries, get space, get staffs. Then gradually the scenario is changing. The current generation seniors, they are trying to develop pediatric nephrology, and it should develop in all the medical colleges. Otherwise, as adult nephrologists, we are many times not comfortable dealing with pediatric patients, like doing kidney biopsy in small children, doing hemodialysis in small children. And it should extend, and many more pediatric nephrologists come up in our country so that the pediatric population will get right and clinical care for the betterment. With this, I thank you again for inviting me here, and I wish this conference will be a success and impart more genetics to our colleagues and others. Thank you.
Thank you, sir. Next, I would request Dr. Dimbendu Rai Chaudhuri, sir, to say a few words.
On behalf of West Bengal Academy of Pediatrics and Indian Academy of Pediatrics, I welcome you all the speakers and faculty who have come from different parts of the country and abroad also. I only say one sentence, that is, this is a matter of pride for the organizer that they have organized such an program, 2-day program, 2 long day program on nephrogenetics only. So really thanks to them. So we can learn many things on nephrogenetics, and we can sensitize our students and the other faculties so that they can use and they can apply the knowledge they have gathered from here in the clinical practice. Thank you. I wish it is a great success of this conference or this program. Thank you all.
Thank you, sir. Next, I would request Dr. Jayati Sengupta ma'am to say something.
Thank you. From BSPN, which is the Bengal Society of Pediatric Nephrology, which is basically the West Bengal chapter of Indian Society of Pediatric Nephrology, which started at a very, with just a few handful of nephrologists, pediatric nephrologists in 2009, has over the years become a much bigger association. And more or less all pediatric nephrologists who have been trained, who have come from different states now here, who are doing fellowships, they are all part of it. And I'm really, really happy that from BSPN we have been able to take pediatric nephrology to a much higher, to penetrate pediatric nephrology to a lot of different sections of among pediatrics, pediatricians, among general practitioners, as well as among adult nephrologists. And this nephrogenetics is such a niche area which even as pediatric nephrologists over many years we have very little, we have not been really exposed much about it much. So it's really fantastic that we are able to learn this, and it's Rajiv's plan that really a very nice thought in the processing of this whole workshop and the 2-day conference. And I really wish the ICH and the ISN combination that we have today a very fantastic workshop and as well as a conference. Thank you.
Thank you, ma'am. Next, I would request Dr. Pratik Das sir to say something.
Good evening, everybody. A few months back, when we were thinking of expanding our Indian Society of Nephrology zone to other aspects like immunology and genetics, so we are discussing with Dr. Rajiv that whether we can do a nephrogenetic program involving both the pediatric nephrologist and the adult nephrologist. And after that, I actually entered a new spectrum, and there is a fantastic people are there like Rajiv, Debolina, Deepanjana. They are doing so fantastic. I was not aware of. So after that, I have some doubts whether my colleagues, our adult nephrology colleagues, will be interested on it or not. So I tried to involve all the people I asked him to involve all the people starting from the very senior most people to the very junior most this conference, and I saw the enthusiasm amongst everyone, although it's a difficult subject, and everybody is so much enthusiastic regarding the learning of the new things that I got. Feel very proud. Thank you, the whole pediatric nephrology team led by Rajiv, and for this conference. Indian Society of Nephrology will be looking forward for arranging such programs focusing on the special population of the society, so that we can explore other than the clinical nephrology is expanding beyond these clinics. There's something in the lab, something in the community we can reach. In the morning we had an excellent press conference and a discussion involving different parts of the people of different parts of the society. So I think the future is there. We'll be arranging more and more conference. Thank you everyone for attending the conference. Thank you Rajiv for arranging all the whole thing. Thank you.
Thank you, sir. Next, I would request Mr. Madhav Chakraborty to come forward and say a few words. Just to inform everyone that he is the state coordinator of Kidney Warriors. This is an organization which have been helping us immensely in providing financial support to children who are admitted with AKI. So thanks a lot to them, and please.
Good evening, everybody. I thank you, the organizers, and Dr. Rajiv Sinha for inviting Kidney Warrior Foundation representation here in this inauguration ceremony of ISN and Nephrogenetic Chapter update and ICH Pediatric Nephrology Update 2025. Since we are working with the patient, kidney patient, we do realize that nephrologists are the angels to them. So my request, if you people do connect with us and do awareness program as much as possible, and that will be the beneficiary to the society. And I wish all success of this scientific event. Thank you very much.
Thank you. I would request our esteemed dignitaries to please come forward for lamp lighting.
I would request all our senior members, including Arpita Di. চলে আসো সুস্মিতা দি ছিল তো পালিয়ে গেছে না সুস্মিতা দি হ্যাঁ আসো মিতা পল দি ডিএস রায় ডক্টর ডিএস রায় অর্গদা जैसे सुबल प्रधान तुमको भी सीनियर बना दिया क्या करें आ जाओ जैती दी बोली है बुढ़ा सुबल सतीश यू आर सीनियर
Thank you all esteemed dignitaries. No academic endeavor can actually be complete without, and it can never be successful without the blessings of our beloved gurus, the very gurus whose wisdom and guidance they continue to inspire us throughout our journey. We are very lucky to have some of them here with us today. That has really made this event a very auspicious one. I would like to express our deepest respect and gratitude to them and felicitate these very inspiring individuals. I would request Dr. Pratik Das sir and Dr. Rajiv Sinha sir to please come forward to felicitate our senior faculty members. I would like to request Dr. Joyanto Basu sir to please come forward for the felicitation. A big round of applause from the audience, please. Thank you, sir. Professor Dilip Kumar Pahari sir, I think sir is not here today. I would request Dr. Pratik Das sir to take this on his behalf, and I would request Dr. Rajiv Sinha sir to give it to him. Next, I would request Dr. Obhijit Tarafdar sir to please come forward. Acha, sir is not here. I think he has not yet made it. Then I would request Dr. S.B. Raut sir to please come forward. A big round of applause, please, from the audience. Then Dr. D.S. Rai, sir. Sir, please come forward. Then Dr. Orgo Majumdar, sir. Dr. Shushmita Banerjee, ma'am. And Dr. Pradeep Dole, sir. Is sir here? Thank you, sir. So while age provides wisdom and experience, it is the young guns who bring the much needed youthful vigor for the advancement of any field. I would also like to take this opportunity to felicitate some of the young pediatric nephrologists who have completed their pediatric nephrology training from ICH Kolkata. And for that purpose, I would like to request Dr. Apurva Ghosh sir to please come forward and present them with their felicitation gifts. First, I call upon Dr. Priyanka Singh.
So, our fellowship, it started, I think, in 2014. And we had Dr. Biplab first. He couldn't come today. And then there was a gap. And then we again had our training. Before we go on felicitation, just one word. Deblina will be getting angry because we are getting late. Arpita Di was not included because we didn't count her as old, and the same reason for Jayati Di.
Okay. So Dr. Priyanka Singh, will you please come forward and...
So we are the only, I don't know whether it is a good or bad, but we are the only center at the moment for the last few years giving training in pediatric nephrology. We do hope that we can inspire ourselves, including Deblina, and sir, with the sir's blessing, maybe starting a DM course. Like we are, otherwise faculty-wise we are ready, but we need sir's blessing. And I also hope that there will be other centers very quickly coming up with fellowships and DM courses.
Next, I request Dr. Niladri Bose to please come forward.
Niladri has been our brilliant as well as the everybody will agree, the most handsome fellow. And now he has settled himself well as a consultant in Neotia Hospital.
Dr. Sanjukta Poddar.
Sanjukta has done she did a training in pediatrics from Delhi, and then she was thinking what to do. And I think personally that she was working in PICU and she chose pediatric nephrology. Most probably she felt that there is less work to do. But unfortunately she is now discovering there is lot of work in pediatric nephrology also. And we are fortunate enough that she stayed back with us. So she is now with us as an assistant professor.
Next, I would request Dr. Deepshikha to please come forward.
Deepshikha is now well settled as a faculty in Dehradun, and apparently Deepshikha, you are the only pediatric nephrology in Dehradun area. Wow! And I didn't believe it when I got a call that she wants to do fellowship only in ICH because she wants to be associated with Rajiv Sinha. ऐसा तो कोई नहीं बोला, मैंने वेस्ट बंगाल में वो तेरा क्यों बोले नहीं. So, and she has been doing, she was very hardworking, and what is very exciting is that she is establishing this specialty in an area where there is none.
And we also had another person, Dr. Suchishmita Saha. Unfortunately, she is not here with us today, and she'll be coming for tomorrow. So I thank Dr. Apurva Ghosh sir.
Thank you, Rajiv, but I think I missed Sushmita, because when Rajiv was not there, it's the Sushmita who was working with me and with a lot of effort, and then Jayati also joined us. But I will always remember Sushmita's contribution to the pediatric nephrology at ICH. Thank you, Sushmita and Jayati.